Good evening, ladies and gentlemen, and welcome to tonight's Wound Care Today and JCN Facebook Live event. A massive thank you to you all for joining us tonight. We're well aware how busy you are in this strange and surreal world. It means a great deal to me and to my team, so thank you so much. Tonight's event is called Mixed Ulceration, What You Need to Know, and our two speakers who are with and thank you for joining us. How are you?
I'm fine, thank you very much. We've been a bit wet here in London this afternoon, but it seems to have cleared up a bit now.
Good. Leanne?
I'm good, thank you. Very excited to be here and just like to thank you for your support towards the Society of Vascular Nurses.
Well, don't be silly. It's the first time we've worked with the Society and it's a real honour and privilege. So thank you for your partnership and your support. So ladies and gentlemen, as you can see, both Louise and Leanne are doing this event from home tonight. So if we have any technology issues, please bear with us. I promise you we'll sort them out as soon as possible. The event will be available on the Wound Care Today Facebook page forever, but also the slides and the event will be available for download at the Wound Care Today website. The link for your certificate of attendance will be made available in the comment bar approaching the end of the event tonight for you to download. So bear with us and that will come up towards the end of the event. As both Leanne and Louise will testify, the more involved you get tonight, the better it is for them, the better it is for the event in general. So please leave comments and definitely ask any relevant questions you may have. And Leanne and Louise will try and answer as many of them as possible before the end of tonight's event. As I've said to you before, thank you to the Society. It means a great deal. Without your passion for education, without your passion for your audience, this event simply wouldn't have happened. So thank you very much. So without further ado, it gives me great pleasure to introduce you to tonight's first speaker. Over to you, Louise. Thank you so much.
Thank you very much, Ed, and thank you very much for that introduction. And I'd just like to start by saying on behalf of the Society of Vascular Nurses, I'd like to welcome everyone to tonight's event and to say that we are really excited to be part of this type of event as it's the first time for us. So tonight we're talking about mixed ulceration and what you need to know. And I suppose the first question to ask is really what mixed ulceration really means. So what I'm going to do is start off by talking about anatomy and physiology of the circulatory system, so what's normal. Then go on to talk about the pathophysiology of the circulatory system, so what can go wrong. Leanne will then take over and talk about how to identify venous and arterial ulcers, how to manage mixed ulcerations, and then why early intervention is crucial. So to start off, talking about the anatomy of the circulatory system. The circulatory system is made up of the arterial and venous systems. The arteries leave the heart and travel off around the body to the tissues and organs. And as those arteries become smaller, they're called arterioles, and then they become the capillary bed or capillary network. At the far end of the capillary bed, the small veins, the venules, join together to form veins to then travel back up to the heart. The lymphatic system also has a capillary bed, and those lymphatic vessels join together, passing through lymph nodes and then go back to the venous system up in the chest. The function of the arterial system is really quite simple. It is designed to deliver oxygen and nutrients to the various tissues and organs around the body. This diagram names all the arteries around the body, but when we're talking about ulceration, it's probably understanding the arteries within the leg and understanding the names of the pedal pulses that you would use when you palpate and do your ABPI. So that's the dorsalis pedis and posterior tibial pulses. The artery itself is made up of 3 layers. The outer layer is the tunica adventitia that's made up of collagen fibres to attach the artery to where it's meant to be in the body. The middle layer is the tunica media, made up of smooth muscle and elastic fibers, so that it can cope with the pressure inside the arterial system. And the inner layer is the tunica intima, which just is a lining within the vessel to make sure that the blood travels smoothly from A to B. The media changes slightly throughout the arterial system. As the artery leaves the heart, there are a lot of elastic fibers, so all that blood leaving the heart allows the artery to get bigger and then push the blood forward, and further along the arteries there's more smooth muscle so that it copes with pressure within the system. At the capillary bed, this is where the exchange of all those oxygen and nutrients occur to feed the tissue and the organs, and this system is all pressure related. So as the blood arrives at the arterial end of the capillary system, the net filtration pressure means that all the fluid, the oxygen and nutrients pass across into the tissues. At the venous end of the capillary system, the net filtration pressure means that all the fluid goes back in with all the waste products to then get shipped off through the venous system. And this is all pressure related because proteins cannot move across this membrane. And that's what creates the pressure differences. And this system deals with 20 litres of fluid a day, so a huge amount of fluid. And what happens with the exchange really depends on which organ the capillary bed is based. So in the lungs, the exchange is around oxygen and carbon dioxide. In the gastrointestinal tract, the exchange is around nutrients and water. And in the kidneys, the exchange is around water and waste products. But for us tonight, the important organ is the skin. The skin is the biggest organ in the body. So the idea is that we exchange the oxygen nutrients to keep our skin healthy and keep infection out. Now, if someone has a reduced blood flow to their skin, the blood that is getting to the skin is going to be used to keep the skin healthy. So any sweat glands or hair follicles aren't important, so they often die off. So patients with arterial disease, you often notice that they lose the hair on their legs, and this is often evident in men rather than women. You will also notice that on their soles of their feet, they can get very dry skin and you can almost peel off layers of skin. And that's because the sweat glands have died off. The skin is also important with temperature control and from the venous side. So when we're cold, our veins tend to go into the body to conserve heat. But when we're warm, they tend to rise to the surface to allow us to lose heat by radiation and conduction. And you often notice this yourself in summer. The veins on the back of your hand will often come out, and that's so that your body can lose heat. So the function of the venous system, as I've just said, one of those functions is temperature control. But the main one is venous return, getting all that blood back up through the system to the heart to go back round again. And it also acts as a reservoir. The vein structure is very similar to the arterial structure. There's the tunica adventitia, the tunica media, and the tunica intima. But there are some differences. The tunica media, there is far less muscle and elastic fibers because the venous system is not under pressure, so it doesn't need so much of those fibers. And also the intima layer has valves, one-way valves, to ensure that the blood travels in one direction. So blood traveling up the leg, we need to make sure it keeps going up, and the one-way valves ensure this. Now, there are three mechanisms that venous return occurs. The first is the cross-sectional area. So though the capillaries are tiny, there are lots of them, so there's a large cross-sectional area. As the vessels get bigger, the cross-sectional area gets smaller. And to fit the same amount of blood from the capillaries through the smaller cross-sectional area, the blood has to speed up towards the vena cava and the heart. Our breathing encourages venous return. So as we breathe in, our chest expands and reduces the interthoracic pressure, and naturally air is drawn in. Also, with that reduced interthoracic pressure, blood is drawn up through the vena cava towards the heart. But the most important mechanism is the calf muscle pump. So our calf muscles have the deep veins within the muscle, as well as the superficial veins near the surface. And when our muscle contracts, it squishes these veins flat, and that pushes the blood out. And because of the one-way valves, the blood can only go up towards the heart. And the last function of the venous system is the reservoir. Now, sitting here talking to you tonight, most of my blood will be sitting within my venous system. If I was to run out and move around quickly, I need blood in my muscles to do the job I'm asking them to do. So the blood moves from the venous to the arterial system. But when we're not doing very much, it's stored ready for action within the venous system. And this diagram really just illustrates the difference between the artery and the vein. So the artery has that smaller lumen and the thicker tunica media, and the vein has a much bigger lumen and the smaller tunica media. So the lymphatic system, the function of the lymphatic system is around fluid management and immunity. So the fluid within the lymphatic system passes through lymph nodes before it gets put back into the venous system. And the lymph nodes really just clean up the blood, but the immunity is a whole nother topic which I'm not going to get into tonight. So really we're thinking about the fluid management that the lymphatic system gets involved with. So this is a picture of the lymphatic system. So all the fluid gets into the system and it gets deposited back into the venous system within the chest, where there are 2 lymphatic ducts. So the lymph system also has a capillary bed, and like the venous arterial capillary bed, it deals with a significant amount of fluid, and 3 litres a day it deals with. So the structure of the lymphatic system is very different from the artery and veins. The lymph vessels have holes in them to allow fluid in, and these holes are larger to allow proteins, large particles, debris, cancer cells, all those kind of things, because they will then this fluid will then go through the lymph nodes to get cleaned up. The mechanism of moving this fluid back up to the venous system is the same as the venous system. It's our breathing and the calf muscle pump. And this system also has valves, again, similar to the venous system. And because this is able to deal with larger particles and cancer particles, this is why cancer is often spread through the lymphatic systems. So pathophysiology, so when things start going wrong. This is a picture of what we call thread veins or spider veins, or their official name, telangiectasies. These are purely cosmetic, won't be giving people any symptoms, are harmless and not something we deal with on the NHS. This is a picture of reticular veins, which are really just bigger versions of telangiectasies. Again, these are usually harmless, not giving anyone any symptoms, and again, something we don't really deal with on the NHS. The problems we do get involved with, because they can cause symptoms, are varicose veins and venous ulceration. So varicose veins occur because the valves in the superficial veins don't work properly. So they're allowing blood up as well as back down. And with blood going the wrong way, it puts pressure on that venous system and on the vein. But we know the vein is not designed to deal with pressure. It doesn't have that thick tunica media, and therefore the vein's response is to go bobbly and baggy, and that's what people start seeing on their legs. If veins are not giving anyone symptoms, we tend to leave them alone because they usually have a deep system that's working perfectly okay, so still can get involved with venous return. You can have patients that their venous system actually doesn't have too much wrong with it, but if their calf muscle pump isn't really working properly, the venous return can't happen effectively. And this is often people that don't use their calf muscle properly when they're walking, because normally we walk from heel to toe using our calf muscle. Patients that shuffle walk, so those that might have arthritis in their hips using frames, tend not to use their calf muscle pump properly and then can get themselves in trouble with venous disorders. And obviously, if someone injures their leg and not able to use their calf muscle properly, that can also cause problems. So if the venous system's not working properly, the venous end of the capillary system, there's too much pressure because the blood is going the wrong way and not getting shipped up the venous system, and therefore the pressure increases, and this causes venous hypertension. And if you've got higher pressure in the venous end of the capillary system, all the fluid that would naturally go into the system along with the waste products can't happen properly. And if the venous hypertension is around for a long period of time, that can cause chronic venous insufficiency. So if someone has chronic venous insufficiency, you can see quite quickly why they would start developing edema, because the fluid can't get back in to the venous system. If the waste products can't get back into the venous system, they stay within the skin and the iron stays behind. And iron is brown, so people start getting brown patches on the skin and typically on the inside of the ankle. And we call this hemosiderin staining. They can also go on to develop lipodermasclerosis. Lipo meaning fat, dermato skin, and sclerosis hardening of. Our skin normally is very elastic, so if you pinch your skin, it will go back to its normal position. But with lipodermasclerosis, the skin has become hardened, you can't pinch it, and it feels quite waxy. There are other skin changes that can occur with chronic venous insufficiency: varicose eczema, atrophy blanche, and then finally venous ulceration. So the skin can't function properly, it's got too much fluid, it's got all the waste products. The skin will start breaking down because it can't function the way that it's supposed to, and you get your venous ulceration. So pathophysiology of the arterial system. Now, arteries do one of two things. They either blow up, as in an aneurysm, which we're not talking about tonight, or they fur up and become narrowed. They become narrowed because of atherosclerosis. And this occurs between the tunica intima and the tunica media, and you get deposits of fatty plaques, and that reduces the lumen of the artery, reducing the amount of blood that can travel through it. And if this happens in the leg, people are described as having peripheral vascular disease. And the first symptom they tend to experience is something we call intermittent claudication. So they get up and start walking around, and initially everything's fine. And with the reduced blood flow going down their leg, the muscle starts running out of blood. So the muscle starts complaining and they start getting an ache and a cramp in their calf muscle. As soon as they stop, that symptom goes away quite quickly. They start up again and initially everything's fine, but it will run out again. So they get a very reproducible pain. If that furring up continues to reduce the amount of blood down the leg, patients start experiencing what we call nocte pain, because we're taking gravity out of the situation. And the only time most of us sit with our legs up for any long period of time is when we go to bed at night. So the patients go off to sleep okay, and then will wake up in the middle of the night because not enough blood is being able to travel down their leg to their foot and particularly their toes. If your patients are describing waking up with a cramp in their calf muscle at night, that's nothing to do with their arterial system, and it's more likely to be electrolyte or dehydration related. Again, if the disease continues to worsen, they start experiencing rest pain. And this is when someone is sitting with their legs down, they're not walking to use up the blood by the muscle, they've got gravity to allow the muscle to get down, the blood to get down their leg, but their tissue on their feet is still complaining it's not getting the blood that it needs, and it's painful. And with rest pain and starting to get tissue loss, people start developing what we call critical limb ischemia. Now, this is quite a dramatic picture of critical limb ischemia, but actually it illustrates quite well the difference between dry and wet gangrene. So dry gangrene for us is something we like to keep in place until we're ready to revascularize someone's leg. And that's because it's acting like a nice scab. It's reducing infection getting into someone's leg. So if someone has a black eschar on their heel, quite often we will leave it there until we know that they've got good blood supply. So once it's lifted off, it will then heal up. But we like it intact until we know that, so it's preventing infection getting in to the person's foot. So we'll often send patients home with dry gangrene. If you're wondering whether we're being a bit mad, we're doing it deliberately, because quite often that area will fall off on its own and be healed nicely underneath. It's acting like a nice scab. But round the little toe area in this picture, you can see it's kind of a bit wet. And if fluid is able to get out, then infection is able to get in. So wet gangrene we don't really like, because potentially patients can get infection and that causes more problems. So when assessing someone's foot, we essentially use colour, warmth, sensation and movement. Or the doctors will often talk about the 6 Ps. So pallor is a pale foot. If someone hasn't got enough blood going to their foot, it'll be pale. But artery disease can give your foot other colours as well to make it a bit more complicated. So quite often some patients can get a very red foot because the body's desperate to get blood down to the foot. So it opens up every single vessel possible, all the tiny capillaries, and therefore you can get a reddening to the foot. You can get some mottling and you can get purple toes. So there can be other colours that can be indicating arterial disease. Perishingly cold, if you've got a cold foot, less blood. So that's our warmth. Normally it's going to be one foot over the other. If both feet are cold, it may be just that person is cold. But if one foot is cold and one is warm, that's a worrying sign for arterial disease. Paresthesia is around sensation. If there hasn't been enough blood down to the tissue, the nerves of that tissue will probably also not had enough blood. So actually it can interfere with the cessation patients feel in their foot. And that's the same with paralysis and movement. You need the nerve to be working properly, and that nerve needs blood to do its job. We've talked already about the different types of pain that these patients may experience, and they'll also have pulselessness. You're not going to be able to palpate or necessarily get a pulse on a handheld Doppler. So problems with the lymphatic system, which is lymphedema, and this comes around obstruction in that system. If the fluid can't travel through that system, you can see quite easily how 3 litres of fluid a day can build up in a leg, causing lymphedema. Lymphedema can either be primary, secondary. So primary, something you're born with. So you have a larger limb and you've had it from birth because there's some congenital problem. Or secondary can be due to some medical problem that someone has had. There's been an obstruction in the system somewhere. It can be because you've had an operation that's disrupted the lymphatic system. It can be related to an operation if you've had your lymph nodes removed because of cancer, and that's why it's quite common for patients who've had breast cancer to often have an arm that's large and has lymphedema. And that's essentially everything from me, so it's over to Leanne.
Hi. So thank you so much for that, Louise. I think it's really important when you start to think about expanding your scope of practice in the management of mixed ulceration that you go back to basics, that you consider the anatomy, the physiology, the pathophysiology, because to me that needs to be very clear in your mind. So when we're talking about the management of mixed disease ulceration, well, identification is key. It's like any other disease or condition that we manage. We need to identify which factors are involved. And mixed disease ulceration is actually used interchangeably For traditional vascular nurses, when we talk about mixed disease, we are talking about having problems with the arterial supply in combination with problems with venous return. But other people can use mixed disease as a terminology if you've got problems with lymphedema in association with venous hypertension. So we've got to be very clear in terms of our terminology. When we're talking about mixed disease, what type of mixed disease are we truly talking about? And just to spend 2 minutes just going over, we are not talking about mixed disease when patients are experiencing chronic or critical limb-threatening ischemia. Those patients are a very different section. Louise has already spoke to you about how this occurs and the symptoms that the patients experience. But just to reiterate that this type of appearance, when you are getting changes on the foot, especially of the digits, we would never class as mixed disease. This would always be classed as arterial disease, and a patient is having critical limb-threatening ischemia. And these type of patients do not need urgent admission. They don't need attendance to A&E, and they do not need an emergency admission. But what they do require is an urgent referral and a timely assessment by the vascular team. And when we talk about timely assessment, we would like these patients to be able to be seen in vascular within 7 days of that referral. This is how time critical we think that this is. So just to be clear that we're not talking about chronic or critical limb-threatening ischemia. When we're talking about mixed disease, I believe that we need to be focusing on arterial ulceration on the limb. So as Louise has already mentioned, in terms of the signs and the symptoms, there are some very classic symptoms. If you concentrate on the limb itself, as Louise has said, the skin will look shiny, just like on this picture. Ulcerations that are arterial normally form on the foot or the lateral aspect of the leg. Not always, but mostly. There's often the skin is completely hairless and the toenails will become thickened. Again, as Louise has explained, because the nutrients are conserved to the most essential requirement, that is keeping the skin cells alive. There may well be localized edema because of this expansion of the capillary bed, trying to get every drop of blood to do its job. You can sometimes get localized edema. But the clues really for arterial ulceration is they develop very quickly. And they are always, unless the patients are diabetic or got absent sensation, they are always associated with significant pain. A feeling of being burnt with a cigarette is something that my patients often describe. The ulcers themselves in the textbook are saying that they will be circular appearance and have a punched out appearance. And this picture shows a classic arterial ulcer on the limb. And you can see that from the condition of the ulcer itself and the appearance of that lower limb. So that's arterial ulceration, which is classic. So let's just spend a moment talking about venous ulceration and those classic symptoms. So this is a classic picture of a venous leg ulcer. But the signs and the symptoms of a venous leg ulcer is actually seen within the limb. So it's looking for those things that Louise has mentioned. The visible varicosities from those veins, the presence of any venous eczema, the hemosiderin staining, the lipodermal and the presence of edema within the whole of the limb, not localized to a specific area, but to the whole of the limb. The ulcer, most venous leg ulcers are around the medial malleolus or the gaiter region. They are irregular in shape, shallow in depth, and they have moderate to high exudate. Now, again, I say this with a degree of caution that this is a classic opinion or appearance, should I say, but not always. So that's arterial and venous signs and symptoms. But actually, for me, the most common factor that I see in the majority of my patients, whether those be arterial, venous, or mixed, is the presence of edema. And Louise has explained why that is so common, whether you've got a problem with the physiology of the venous system or the arterial system. The way that lymphatic bed connects makes both of those pathophysiologies impact on that ability of the lymphatic system to do its job. So edema initially is formed and it's soft and has pitting effect. But over time, that there is chronic skin changes within the skin. You have fibrosis of tissue, which leads to eczema, hyperkeratosis, lipodermatosclerosis, and my favourite definition, wet legs. Now, I urge you all to please challenge that definition of wet legs, because legs don't leak for no apparent reason. There is an underlying cause where that patient is experiencing that lymphorrhea. And if you do not manage that initial lymphorrhea, that patient will end up with ulceration, and you will only be prolonging that patient's suffering. So as soon as you've got that, there is a high risk of that breakdown of the skin and the formation of a venous ulcer. So Louise has already identified what's the causes of the cause of arterial ulcers. And to me, this is quite clear in your mind. If you think, why did that arterial ulcer occur? Well, it's quite easy. Lack of blood, reduced blood supply, lack of oxygen, areas of cell death, tissue death leads to an ulcer. Quite easy to get round in terms of why does that happen. But if you think of the reasons why does it happen, it won't be managed by any other way than revascularization. We need to get more blood down into that leg. And within a vascular service, there's only really two main methods of getting blood down into that leg. An angioplasty, which is the stretching open of the artery. Sometimes we use stents within that procedure, but sometimes not. Or bypass surgery, replumbing. So if you look at these pictures that you can see on the screen, the first picture on the left-hand side, you can see that there's a blockage within the artery. You can see that there's a significant blockage, but you can see the body's trying its best to get more blood down there by the twisty and turny little vessels that you can see. And these are called collateral vessels. But you can see that once we've actually angioplasted it, we've tried to remove as much of that atherosclerosis as possible. You can see that the next picture shows that we've got nice good flow. And wherever possible, we will always try to treat a patient with a angioplasty first, because this is classed as an endovascular procedure, often day case, often under local anaesthetic, with minimum risks associated. So we always try that wherever possible as a first line approach. But if that's not possible, then we always consider bypass surgery. And bypass surgery is just like plumbing. You can see on the cartoony image that if a patient's got a blockage within their superficial femoral artery, the one that runs down the thigh, we simply put a new piece of piping from above the blockage and plug it on below the blockage. We all work with great vascular surgeons, and actually at times still what they do to this day is still impressive. If you can see on the bottom image, that's actually what we call a crossover bypass. So the blood is actually occluded going down to the left-hand limb from the level of the aorta. But you can see what they've done. They've actually tunneled a new vessel through the pelvis, pinching the blood from the right leg to supply the blood on the left leg. So if you have any form of arterial disease, we need to be considering revascularization, because that's the best way to improve their chances of healing. Now, even as a qualified nurse on a vascular ward, I really had it clear in my mind how an arterial wound was caused. What I could never really understand was, why does venous hypertension and having more blood in the leg cause an ulcer? Because surely extra nutrients is a good thing, isn't it? Not a bad thing. And as Louise has explained, when the nutrients get stuck into the surrounding skin, in effect, they cause an inflammatory reaction. And that internal inflammatory reaction is simply the same as scratching your skin and causing inflammation constantly. Those extra waste products, proteins, water molecules, all of that causes irritation, internal inflammation, and it's when the white cells activate as part of that inflammatory process that the venous leg ulcer occurs. So if anybody asks you the question, why does a venous leg ulcer occur, the quickest, simplest answer is chronic inflammation internally. But if you think of what Louise has said, there are proven pathophysiologies as what's happening within that venous system. And Louise mentioned that we need to think about what type of disease within that venous system. Is it a structural problem in terms of valve incompetence or venous obstruction? Or is it a functional problem in terms of dependency or loss of calf and muscle pump? And it's really important that you assess the patients for which of these parts is the patient suffering from. And the reason for this is that in a large proportion of patients, venous hypertension is curable. So how do you determine whether a patient has got structural or functional venous disease? Well, you can do this if you're skilled with a handheld Doppler. However, it is gold standard that patients actually undergo venous ultrasound scans, so venous duplex scans, because they can actually determine the competency, how good the valves are working, and what's the flow like within the veins, within the superficial system, and also the deep system. And the reason why that this is so important is that venous ablation is a way of curing venous hypertension. We use this a lot for symptomatic varicose veins, for patients with discoloration of their lower leg. But what we haven't been good at, especially in the UK, is using this for patients with active venous ulceration. Venous ablation is a walk-in, walk-out, minimally invasive procedure that's done under local anaesthetic. It's suitable for everybody. It doesn't matter really how old you are or how unfit you are. And the reason why that this is so important is that we have randomized controlled studies called the EVRA study, which shows that actually if you apply compression therapy compared to applying compression therapy plus ablating the veins, you get substantial improvements. And we know this from a large multi-center randomized controlled trial. And the results showed that if we ablate the veins at the same time as applying compression therapy, we heal these patients 30 days quicker, and we have healing rates up around 86% at 24 weeks. Now, if you think about your caseload, how many patients have you got on your books currently with ulceration that's been ongoing for greater than 24 weeks? It feels a lot more than 15% of your books. And you may or may not be aware that this is already recommended by NICE. It's there and it should be commissioned across the UK. The problem is that this guidance is hidden within the varicose vein recommendations from NICE. But it clearly states if a patient has got venous ulceration, they should be referred to a vascular centre to undergo assessment of their venous hypertension to see if it is structural in terms of can it be repaired. But this always has to be in combination with compression therapy for any form of venous disease. Compression therapy is the donkey, if you like, of managing a venous leg ulcer. We know for many decades now the power of compression therapy. We have randomized controlled trials, systematic reviews, and meta-analysis. But if I ask you as an audience, what level of compression does a patient need? You'll all be shouting at me 40 millimeters of mercury pressure. I just want you to remember how dynamic and how changeable venous pressure is. Louise has talked about how blood moves back up through the vena cava, but the venous pressure changes substantially, whether a patient's laying down, rising, walking, standing for a period of time. So all of this is a dynamic pressure that is changeable at any moment. And with that, you need to think about, okay, so is everybody needs 40 milligrams of mercury pressure? because I would say that you need to be thinking of everybody needs a minimum of 40 milligrams of mercury pressure for pure venous disease, but many patients may require 50 or even 60 milligrams mercury pressure. You don't need the same pressure on your lower leg if you're a 4-foot lady compared to a 6'6" man. We need to be thinking of individualizing the amount of compression that's needed. So I'll leave that thought with you. So in terms of how do you determine which of these factors are in play with these patients? Well, it's quite easy. You're already doing it. It's about taking a detailed history from a patient. It's about looking at those vascular risk factors. Have they had a stroke? Are they diabetic? Have they had a heart attack? Are they more likely to have peripheral arterial disease? It's about that physical examination of the patient and of the limb. And it is about talking to the patient about the history of the ulcer. How did that occur? Did it happen spontaneously? Was it part of trauma? How did that occur? There is always a physical assessment that's required when you are diagnosing the etiology of a leg ulcer. But please, can I just, before we go on to talk about the ABPI, the ABPI will never be able to confirm to you the presence of venous disease. The ABPI will only be able to confirm or deny the presence of arterial disease. So in a way, it's a safety check of what level of compression is your patient suitable for, but it will never help you diagnose a venous leg ulcer. So many of you out there will be very competent already at Doppler assessment, but just in case we've got people that aren't, a Doppler assessment is an easy bedside test. It's a simple ratio. It compares the blood pressure of your arm to your leg, and in a normal, healthy individual, that those two things should be completely equal. An ABPI, though, shouldn't be conducted if the patient has untreated, unconfirmed suspected DVT. However, once a patient has had one dose of anticoagulation therapy, that patient then is safe to have an ABPI. Please don't do ABPIs in patients that are sitting down or you can't get to a semi-recumbent position. They're completely unreliable and you're wasting your time. And we do need a degree of caution for any patients that have got vulnerable skin in those areas. So just to remember how to calculate an ABPI, the first thing you need to do is to take the blood pressure on both your arms, and it needs to be on both of the arms. And you only take the highest pressure. It doesn't matter whether it's your right leg you're assessing or your left leg. You do both arm pressures and you take the highest pressure. And then you record the pressure from at least 2 pulse points on the leg that you're interested in. So if you look at this diagram and we look at the left leg, we've recorded the foot pressures for the dorsatus pedis of 150 and on the posterior tibial of 130. We take the highest of this measurement, 150, and we compare it and divide it by the highest pressure of the arms, that being 150. So 150 over 150 gives you a ratio of 1, which simply means the patient's getting 100% of the blood getting down to the leg. And if we do the same calculation on the right leg, we have a dorsatus pedis measurement of 65, a posterior tibial measurement of 75. We take the highest, the 75, and we divide it over the highest pressure of the arm. Once again, not dependent on which arm, it's the highest pressure. So you simply do a calculation of 75 divided by 150 equals 0.5, 50% of the blood getting down there. And we've got clear documentation across the UK, which is normal and what's not normal. What I would say with an ABPI though, trust it if it's low, question it if it's high. If it's going above 1.3, you can question really, is that a reliable reading or not? If you've got calcification of the arteries, it's probably going to be unreliable. So the treatment for mixed disease ulceration isn't mystified, it's relatively simple. Many community nurses out there are really scareful about the management of this, but please don't be. You're simply managing those individual elements. You're going to manage the venous, the lymphatic or the arterial, but what you need the skill set to be able to do is to establish what is the predominant factor. Because if the predominant factor is venous or lymphatic, they need a form of compression therapy. If the predominant factor is arterial disease, they need to explore revascularization. Compression therapy, if you've got mixed disease and a reduced ABPI, we need to be thinking about using a lower strength compression. So something around 23, 27 milligrams of mercury pressure. But we're not worried about you actually causing restrictions of the artery by getting the bandage too tight. We're actually worried about the perfusion of the skin and whether you're actually going to cause pressure damage. So you're never going to be a tourniquet to the artery, but you may put too much pressure on vulnerable areas. The best way to do this is to protect the vulnerable areas and check a patient's sensation. If the patient's got an intact sensation, they're never going to allow you to put on a bandage that's too tight or too uncomfortable. We know that compression therapy is safe. We know that it's safe to be used in mixed arterial ulceration, and we know that it improves the venous and the arterial perfusion. We know this from good quality studies. And the reason for this is that relationship between the lymphatic system. If you have edema, you will always reduce your venous return and reduce your arterial supply. So some form of compression can actually optimize both systems. Both of these pictures that I'm showing you now have got classic mixed disease. Their ABPIs are 0.7-ish. But you can see from both of those legs, they are crying out for compression therapy. Use your skill set. The damage that you're going to be able to do with this type of patient is minimum. You are going to improve perfusion. We know we can safely use compression even in the presence of arterial disease from the previous studies that's been undertaken. Because compression offers many benefits. It will help with the venous incompetence and the edema. If you've got venous incompetence and edema, this will cause some degree of reduced arterial flow. Venous hypertension reduces that intervascular pressure gradient, so therefore you're actually reducing the perfusion pressure. Edema pushes the capillaries apart, leading to increased distance, so those blood products and those oxygen cells and the nutrients has got a further distance to be able to move across and to transport that. And compression therapy improves all of the above. You may all be thinking of this, but gosh, what if? This picture of bandage damage is rare. And actually, this is pressure damage, not damage from the bandage, as in the compression. It's because we had not enough padding on that area and we were treating that leg wrongly. If in the presence of edema, always consider using some form of compression bandaging of a reduced nature. We need to ensure that we are not so worried about this. The chances of causing bandage damage is really, really small. How many wet, leaky legs do you see that go on for months and months and months? Somehow we've got the risk and harm balance wrong in our heads. Please don't be fearful of this. I encourage you all to think of these ulcers as a weed. All you're seeing is the leaves on the top. You need to be Miss or Mrs. Mr. or Miss Marples, and you need to think about what's the underlying pathophysiology. Where are the roots of this ulcer that I'm looking at? Is it mostly in the venous system? If so, compression therapy. Is it mostly in the arterial system? If so, revascularization. And when we talk about compression in a mixed disease group, it is reduced or modified compression, not full strength compression. Please have confidence in this sphere. Sometimes your unconfidence and your ability to think, gosh, I'm going to harm the patient, actually the apathy can cause harm. We've got nearly 500,000 patients out there with a leg ulcer without a diagnosis of their underlying pathophysiology. Would you like to be suffering a condition without actually knowing the reasons why, what's going wrong? We know that the older the ulcer, the harder it is to heal. You have a significant opportunity to heal an ulcer, but only in the first 6 months of its life. We have got really poor healing rates across the UK of only 47% of healing at 6 months. We can do better. You are, in effect, causing harm if you are delaying that assessment and if you are wondering, is this the right thing? I encourage you all, from today's session, increase your confidence. You now have a greater understanding of the venous, arterial and lymphatic system. You've got increased knowledge of those treatment options. You know a little bit more about what vascular does. I hope you've got an improved understanding of compression therapy, that this is actually an anti-inflammatory device and a very potent and powerful one, which can be safe to be used in mixed disease ulceration. I hope that we've tried to increase your confidence. I hope to improve your decision making. And I would just urge you all, and I love this little slogan, keep calm and remember you are great. Nursing staff are always trying to do the best. You are here on this evening trying to increase your knowledge. I'd just like to say thank you for all that you do. Please make contact with your local vascular team. We are a friendly bunch. We would love anybody to come to spend more time with us within a clinic settings, to buddy up for some mentorship, to help to increase your practical confidence in this level. I hope you've enjoyed this session. I'm going to hand back over to Ed to see if there's any questions.
Leanne, Louise, I just thought that was absolutely exceptional. Thank you so much. And also to our audience, our vast audience, for all your comments and questions. Your engagement makes a massive difference, so thank you. Before we get on to the questions, which I want to do quickly because we've got 10-15 minutes left, I just want to do a little big up for the Society of Vascular Nurses. On the screen in a second, their website is www.svn.org.uk. Membership is absolutely the lifeblood for their organisation. They have some incredible resources. They run amazing events. They have some fantastic publications, not just throughout the year, but in archive form as well. So please, if you want to support this amazing society, go onto their website, have a look at membership. So there's a little sales pitch done. Guys, thank you. Are you okay if I get on with the questions?
Yes.
Fantastic. So question number one, is it safe to compress if you cannot record an ABPI?
So I suppose I ought to admit before I answer that yes, I do. And like Leanne was saying, it's more about your clinical assessment, because an ABPI at the end of the day is a number. It's not a diagnosis, but you add that to your clinical assessment. So if you've got someone young, fit, healthy, who you think has got a venous ulcer, got a nice warm foot, you can palpate their pulses, reality is you're probably okay. And as long as you're documenting your rationale. The opposite is if you've got someone with a cardiac history, slightly confused, so is unlikely to take the bandage off if something's not quite right, you may not want to. Bottom line for me, it's about your clinical competence and your expertise. And if you're unsure, then sometimes it is worth checking, because as a qualified professional, you need to make sure you're doing the right thing.
Thank you. Leanne?
Okay, so in an ideal world, everybody would have an ABPI, and I've got no issues with them. The problem is there's so many barriers to getting an ABPI, which causes lengthy delays for a patient. And I find all of those completely and utterly unacceptable. I appreciate that within the majority of policies across the UK, the ABPI is the key. And if it's not 0.8 to 1.4, you have to refer on. How horrible is that for a patient point of view? Wait to see another specialist. As you know, that I'm working with the National Wound Care Strategy, and we've really tried to tackle this. We've said that yes, try to get an ABPI, but I'm like with Louise, I can't tell you last time I did one, and I put compression on many patients because I use all my other skill set. The ABPI shouldn't be the only key to the compression door. And remember, the National Wound Care Strategy is now saying you can put on 20 millimetres of mercury pressure with a simple red flag assessment. So long as you've screened out critical arterial disease, well, actually, they're endorsing that you can put 20 millimetres of mercury pressure on initially without an ABPI. So, I can't wait to do a research study looking at clinical decision-making versus decision-making based on a number, because I think the clinicians are much better than a simple maths calculation.
Correct, and thank you. So moving on to question two. I love the fact you're simply not sitting on the fence, so long may that continue. Question two, do the same principles apply in mixed etiology ulcers when one of the components is an inflammatory disorder? Leanne, do you want to start with that one?
Yes, because actually, well, it depends on how technically you want to get. Venous disease is an inflammatory disease at the end of the day, and you cause chronic inflammation in the cells, hence why you go down that picture. So, yes, you should still be treating those patients with compression. There's a great debate about whether arterial disease and atherosclerosis is actually an inflammatory disease based on the irritation, if you like, of the cell wall. And that's one of the theories that people describe in terms of the presence of expanding peripheral arterial disease. And there's been a lot of studies about trying to deliver local therapies to reduce that area of internal inflammation in the middle of the vessel. So I think inflammation is the cause of many diseases. And I think that the more that we understand inflammatory processes, the better we will get. Any type of respiratory disease, arthritis, anything like that is all based on chronic inflammation. So I think that the more that we can tackle that and the more that we understand that, the better it will be. Is there a definitive answer to that at the moment? No. Research is ongoing.
Thank you. So question 3, and maybe Leanne, I'll throw this one back to you to start off with, and then Louise. How do you best manage copious amounts of exudate and pain that patients experience in leg ulcers of mixed etiology? Pain is so bad they can't tolerate reduced compression.
I'd love to know the answer, to tell you the truth, because it's that type of patient that still causes me and my team the worst of the head scratching moments. When you've got a patient with significant pain and significantly weeping legs, and they try the best to have a degree of compression on, but they're simply unable to tolerate it, your heart goes out to them. There is no simple solution. I think that the key to it really is to try to encourage that patient to go to bed. If the patient is resting in the chair, you're just going to perpetuate the problem with the dependency, the increased pressure on the lymphatics, and the increased amount of exudate that's coming. Don't give up on them. Don't leave them in wet bandages because it's simply unacceptable. Try pain management. Try anything you can in relation to pain management. So a lot of our patients with arterial disease go down the line of having specialist pain team inputs. That type of patient, we should certainly explore any options for revascularization, because that may reduce the pain ever so slightly, allow them to apply a little bit more compression. Also, watch this space, because there's some great things out there that's coming in the new sphere of things. There's something called FlowOx, which is specifically designed for this, and also Wound Express, which is a way of increasing peripheral perfusion as well as venous return by the use of dynamic pressure, like pneumatic pressure that's delivered actually on your thigh, not on the leg itself. So they're a challenge. Exudate management is key. Analgesia is key, but I haven't got your golden answer. I'm so sorry.
Louise, do you have anything to add to that?
Well, I was just going to say, it's the day-to-day management, exactly what Leanne has said. It's just trying to find mechanisms to control everything, but it's ensuring you're getting that referral, getting the early treatment to deal with the underlying cause to help start correcting it. Because though bandaging and dressings will try and support the venous system or help the arterial system, until you've corrected the underlying cause, this is just going to continue to go on.
Brilliant, thank you. Incredibly, we're coming to our last question. The hour is up. It's amazes me how quickly the time flies by. So last question, and maybe Louise, if you start with this, and obviously massively relevant and an exciting question with regards to your society. How does a nurse become a specialist VM?
Yes, very good question. I think we all, if you talk to a lot of vascular nurse specialists, we've all found our roots in various different ways. I personally was working on a vascular ward within a hospital, and from there developed my skills to become a vascular nurse specialist. But I know people have come from various backgrounds. It's getting your ties with your vascular unit, make yourself known. There are various courses and education that you can get involved with, and it's like anything, go for an interview, because actually if you can sell yourself and you're the right person, you don't always need all the skills that they list that you need to do the job. It's just the fact that if you're the right person for the job, they'll take you on.
And I would just echo that, and I'd say if you've got the passion, find the doors, push on them. If you can't push on them, just get a sledgehammer and break through them. If you want to become a vascular nurse specialist, the best place to hone your skills is on the vascular wards. You know, all of us within the society has come through that route. One thing that me and Louise are very passionate about, though, is that to get to where we are in terms of senior vascular nurses and nurse consultants, we've had to fight our way through every step of that. Me and Louise are very keen to leave a legacy for the next generation of nurses to describe that route in terms of an apprenticeship route of what do you need, skill set, knowledge base to be able to go from that band 5 all the way through to a band 8C if you want to, and what does that line look to. So hopefully one day the Society of Vascular Nurses will be able to produce that, and I know it's something certainly that NHS England are wanting us to push for, to look at whole nursing careers.
Guys, brilliant. I thought tonight was fantastic. From beginning to end, and I'm not alone in that. We've had thousands of delegates watching in tonight, and your comments, your incredibly kind words are hugely appreciated. Leanne, Louise, please watch us back. There's some fantastic things that have been said. I'll phone you both later with some of the best ones. The certificate link is now available to download. That should be either on the screen or in the comments piece down the side. For more events, please visit our Wound Care Today or JCN websites. And as I said before, if this interests you in any way, please join their society. I know they'd appreciate it. There's huge resource and events going on there. That concludes tonight's event. Thank you, Leanne. Thank you, Louise. Again, it was brilliant. And to the whole society, your support means a great deal. To the team at the JCN Wound Care Today in Mull, thank you for your incredible hard work for delivering another great event on an evening. And last but not least, to the incredible delegates, you guys, you healthcare professionals, you continue to humble me, the team, the nation. Have a lovely evening, stay safe, stay strong, and enjoy the last few weeks of this strange British summer. Good night, and thank you very much. Goodbye.